Hello, everyone, and thank you for joining us for today's training, a transdisciplinary approach to behavioral health populations in primary care. My name is Rick Brown, and I am the Senior Director of Communications, Membership, and Special Initiatives with the Association of Clinicians for the Underserved. I'll be your host for today's training. If you have any technical issues during today's webinar, please reach out to me or my colleague Josh Chung for help. Also, on our next slide, you'll see for those of you who are new to ACU, we are a transdisciplinary membership organization uniting clinicians, advocates, and organizations in the shared mission to establish a robust, multifaceted workforce to help transform communities to advance access for quality care for all. We do that by providing advocacy, professional education, training and technical assistance, and more to develop and support clinicians and the healthcare workforce caring for America's underserved communities. We invite you to learn more about us and membership of ACU at acu@clinicians.org. If you are interested in more resources on behavioral health for community health centers and other institutions working for medically underserved communities, we encourage you to visit our Behavioral Health Initiatives page, where you can find archived presentations, upcoming webinars and events, and more. We also encourage you to save the date for our upcoming 2026 Behavioral Health Leadership Forum, a full day of CE/CEU accredited workshops, discussions, and more on best practices in behavioral health for clinicians and leaders at community health centers. More information, including details on potential scholarships to help attendees attend the event, will be available soon. I'll also ask Josh if he can put the link to our behavioral health initiatives in the chat. Oh, he's already done so. Thank you, Josh. And you can also scan the QR code, which I'll leave on the screen for just a moment. Okay, and then moving on to the next slide for housekeeping items. First, we will be recording this session and we'll share the recording and the slides with you within a week of the webinar. We also encourage you to ask questions via the chat during the presentation as you think of them, and we'll also have a dedicated Q&A at the end of the session. Also, please complete our evaluation if you can at the conclusion of the training. It's tremendously helpful to help us improve the quality of our educational events. And lastly, on our last slide, I am honored to introduce today's speaker. Dr. Verna Little is the co-founder and special advisor for advocacy and research at Concert Health. She is also the chief operations officer and a co-founder of Zero Overdose, as well as a member of ACU's advisory council. She is a national expert in suicide prevention and collaborative care, a faculty member for Zero Suicide, and previously served for over 2 decades as a senior vice president for a large FQHC network in New York. We're very excited to have her presenting with us today, and with that, I will turn it over to Dr. Little to kick us off.
Well, thank you. I'm very excited to be here and really excited to get a chance to talk to everyone today. It would be super helpful for me, maybe just put in the chat. I will be watching the chat as we go along. I have learned to multitask around that, but helpful for me to just see what role you're in the health center. Hopefully we have some CEOs and some CFOs today. Glad to sort of have some of those discussions. And I also wanted to start and just kick off, and I think I would be remiss not to mention some of the incredible duress that the behavioral health field and services are under today, following sort of some very late yesterday, overnight, early today cuts for behavioral health, substance use, suicide services. And so I think we are still figuring out the breadth, depth, and impact of all of those services, but I know many of you are likely affected and may have had SAMHSA grants or other services. And so I think more than ever, it is going to be really important to understand your behavioral health service lines, to have a strategy around your behavioral health service lines, and to optimize any revenue billing and coding efficiencies around your behavioral health service lines. So we are certainly glad to be here and to be a resource. And I apologize if your day, like my day, was a little bit turned upside down with some of these developments. So certainly glad to answer any questions or sort of talk about what that might look like. And again, I appreciate all of you putting in all of your different, looks like we've got a lot of behavioral health supervisors, we've got some directors here, so thank you for putting that information in. Again, I'm going to watch the chat, so feel free to put some some information in or questions, and we can either stop and answer them as we go along, or we'll be having some time for conversation at the end. So it is really important to understand your behavioral health service line. I love FQHCs and RHCs, and I get an opportunity to work with them a lot around the country. And oftentimes, when I will talk to CEOs or talk to behavioral health leaders, I'll say to them, tell me a little bit like, what is your cost per visit for behavioral health? And I'll ask some sort of questions, and people don't know. They know what the cost per visit is for primary care. They might have other informations. And one of the things that we focus on in our meeting, our annual meeting that Rick mentioned earlier, is really giving and arming behavioral health leadership with the information that they need to ask the right questions and to actually run their service lines and be responsible for their service lines. But I think more than ever, we have to think of behavioral health as a service line. It should have clinical outcomes. It should be financially sustainable or revenue producing, and really should be an arm of all of the services. So we're going to talk a little bit about some of the different models for care, what that looks like, populations, some examples, and again, be available to sort of answer any questions as we kind of go along. So thinking about what do I really want people to come away with, I always think a great webinar is things that I can leave and go, oh, I can actually do that today, or that gave me something very concrete to do or think about. And so really thinking about what your strategy is, how does that benefit the people you care for, the providers in your system, and the organization as a whole? To think about what some of the common challenges are. So do you have some difficulties that cross all of your service lines? To really understand the different approaches, and we'll talk about that a little bit. A lot of times people say, well, we do integrated care, what does that look like? And you really do need to have a strategy around what that looks like and how you think about it and what you think about in terms of your behavioral health services. So when we think about as a team, all of you are, certainly drank the Kool-Aid around team-based care. I think when you think about team-based care, it looks really different when you actually implement it so that it goes from the bottom of your organization to top, and think about what that looks like. So I know all of you have sort of taken this on, and it looks a little bit different across your organization. I put the definition of integrated care here so that we can all level set. But to be honest, I'm not really sure it matters as much as thinking about what your organization does to adopt optimal care and to optimize some of the evidence-based practices that are out there. And so really thinking about how do we think about integrated care. And when I think about integrated care, also, like we're talking about behavioral health, and for some of you who know me, I could talk about behavioral health all day long, right? But also, are we integrating dental? I have a friend who has done a wonderful job at an FQHC, Shelby, if any of you know her, and she's done a lot around dental and really bringing dental in and incorporating dental into some of the screenings and the work, and really integrating them with behavioral health. So really thinking a little bit more broader. One of the things about really weaving in behavioral health, and I'm saying integration, but I'm really meaning behavioral health. Each year when we gather in DC and we have the behavioral health leaders there, oftentimes what I hear is, I always feel like I'm fighting for a spot at the table. I always feel like I'm having to fight twice as hard as some of the other service lines. And I think that that is some in terms of how we structure our behavioral health leadership positions. Am I responsible in my job description for the financial optimization and success of my service line, right? And also when we think about, is there a behavioral health subcommittee on your board? Is there a behavioral health provider on your board, right? Do we think about behavioral health? Is there a seat on the compliance committee, on the quality committee? Like, is it really broad across your organization so that you truly embrace behavioral health service delivery as not only a service line that's accountable and viable, but also a service that spans the breadth and depth of your organization. Are they part of interviewing and hiring? So is behavioral health leadership part of hiring, a new CMO or some medical leadership? What does that look like? And sort of vice versa. And that actually is going to be incredibly helpful when you think about what that behavioral health service line looks like, and also the role that the behavioral health leadership play in the organization. I did something with a health center in New York, and I was working with them to recruit a new behavioral health leader. And we said, wait a minute, what do we really want this person to do, right? And we really revamped that job description, and they changed it to be a chief behavioral health position. But we changed what they were really accountable for, that there were some clinical outcomes, that there were quality ties into some of the organizational quality, that there was an understanding of some financial ownership. And that was incredibly helpful in terms of changing how behavioral health was viewed and how it was really integrated into the overall organization processes and services. And so really thinking about what that looks like, and then really taking on in your organization sort of this thought of no wrong door. So one opportunity I know that organizations will often take is they will look across all of their services. So I know at one point in a health center, I had like WIC for women, infant, and children. I had some substance use services, primary care, specialty mental health, some health and behavior change kind of services, some women and children's other, services. I think I had healthy steps. And when we sat down and we looked at all of the intakes and all of the information that was gathered every time somebody came in for each of those different services, and we said, wait a minute, what does all of this have in common? What could someone ask that would be helpful for another service line or another service? And we actually put it all in one place in the record so that it really reduced a lot of that duplication. And it was really interesting because then those services became a little bit more seamless. And I think that grew out of that effort. And so if there are opportunities to do that, then that's going to be incredibly helpful. And also, how do people transition across services in your organization? What does that really look like? Are they seamless? A lot of them are services, programs, and grants in your behavioral health service line. And does that actually look seamless to someone, or do they feel like they literally are walking down the street and into another service provider, which can often happen, especially if a lot of your behavioral health services or related services are grant funded. It's like they're very siloed around those grant deliverables, and they often function a little bit more independently than might be optimal for sort of an organizational overview. So one of the things that we often see with behavioral health service lines, and I hear this all the time, and we can kind of take it on. One is, again, a lot of the behavioral health leadership says, I actually have no window to understand my finances. Billing sort of doesn't get back to me. I don't know if they're denials. I don't actually know if I'm revenue producing. I don't know the right questions to ask. And so one of the things that's incredibly helpful is to start to think of, what don't you know? What would you need to know, and why do you need to know it in order to successfully manage? What is your cost per visit? What is your revenue? What is that margin? What does it look like? One of the other huge barrier, or I don't want to say barriers, challenges in behavioral health service lines and FQHCs is that there are oftentimes, when I look at a schedule, it's completely full. We don't have any availability. But if I look at that same schedule a week later versus how many people actually kept that appointment, then what we find is that there is a considerable number of slots on that schedule that didn't get utilized. And so that becomes a problem because you have providers that are not optimized, even though their schedules are full, right? So you see that oftentimes, and there's lots of different reasons that that can play out. Oftentimes we have wait lists at the same time. So we have time in the schedule that winds up not being used, and then we have people waiting for services. And then I still actually talk to FQHC providers. I talked to one the other day, and their services are underutilized. And a lot of times that's because they're just depending on provider handoffs, maybe, or um, we haven't really figured out ways to be able to optimize. So all of those problems have different solutions. It sort of depends on, thinking about who are the population of people that maybe are not coming in, what percentage of time is actually not filled. I call it, you can't treat an empty seat, right? You can't. And so how many of those slots are not used for no shows, for cancellations? I don't actually think no show is an important number because it doesn't matter why you have an empty slot. An empty slot is an empty slot. And so, when are those slots? Who are not using those slots? What does that look like? Is it people that are new? Is it existing people? What does that look like? And there's been a lot done around scheduling optimization for behavioral health service lines and FQHCs that kind of come at some of these challenges and really help work through them and have made dramatic differences in terms of access to people who need care and really working to be able to meet some of the financial sustainability needs. Also, outcomes, more and more talking about outcomes in behavioral health. So, if we haven't thought about outcomes in our behavioral health service line, then that's something we really need to think about because, regardless of what service we're providing, then we want to make sure we know what success looks like, that our team knows what success looks like, our providers, our patients, so that we have a real understanding and also that we're serving our entire population with the right care, the right touches, right? And we've learned a lot in behavioral health about sort of what that looks like and how we can try to do that. So we start thinking about what this looks like in terms of really thinking about integrated care. How are we looking at the clinical integration? What is that looking like organizationally across the system? And our population, how are we taking care of our population of patients with behavioral health needs? What is their experience? How are they utilizing it? What does it look like on the finance side? So as you go forward, you could actually take this and start to put some thoughts down in these different areas with some things you want to look at, some things you might want to measure, some things that you might want to think about with your team to really go forward. So we're going to take a couple of thoughts here around some implementation. One of the things we have learned around integrating behavioral health is first and foremost, we don't do it anywhere near how we used to do it even 2 to 3 years ago, whether it's a model or whether it's just bringing a behavioral health provider in. That there is a lot that needs to be done that looks very different. How does that scheduling look different? What outcomes right from the beginning? What are some of the thoughts about the kinds of evidence-based practices we're going to use? How are we communicating to providers so that everybody knows an outcome? Like, I'm a behavioral health provider, I'm a psychologist and a social worker, but I know what A1C goals we're working towards, right? So if you talk to your primary care providers in your organization, do they know what outcomes are for your behavioral health diagnoses? Do they know what scores they're looking for on tools? Is there a general sense across the team of what that looks like? I've gone into so many organizations and the primary care providers didn't even know that there were behavioral outcomes or what they were or to be able to be part of that. So thinking about what that looks like. So, starting to talk a little bit about the terms, I think they're used a little bit interchangeably, and I wanted to just clarify them a little bit now. So, when we think about multidisciplinary, right, we've got our multiple disciplines there. When we think about interdisciplinary, right, we think about we're really starting to share information. We've got the same, notes on the EHR and sort of all of that things, right? But we're a little bit more specific around the disciplines. So when we think about transdisciplinary care really becomes the gold standard. Transdisciplinary care sort of takes the best of what we've learned and really folds it into what we know is incredibly helpful, sort of on the ground. So when we think about what is important. First of all, what is super important is this idea of shared training and communication. So there are some things that I need to learn when I'm joining the organization that also primary care providers need to learn, right? So there's this idea of shared training and shared care plans. So one of my favorite things to do is to go into an organization and pull out all of the care goals that patients have. Here's from the diabetes educator, here's primary care, here's behavioral health, here's maybe, another service line or program, and say, okay, look at all of these goals that were on someone's care plan. Look at all the people that set them. Sometimes I've seen as many as 17 different ones across, a patient's care. And so, how can we actually start to bring them into one? Because at any given time, really, someone can focus on one thing, right? So maybe my homelessness is primary, my diabetes is primary, my depression is primary, whatever it happens to be, the team kind of needs to rally behind one and support. So I see that you're really focusing on, finding some housing or a place to stay. I see that you're on some medications that need refrigeration. Let's talk about how to make that happen, right? Or how that can be. Or maybe we need to talk about different meds, or maybe you need to come in here and get your meds. But let that actually be a goal that we're going to try to work on and figure out. Get taking your medications and making sure they stay refrigerated. And so ensuring that we're rallying behind one goal and then we can change it. I kind of call it like the what's on fire diagnosis, and then everybody can kind of rally. Because if I don't have a place to stay, then all of these other pieces aren't going to fit together. And if I'm, having a psychotic episode, then a lot of the other pieces aren't going to come together until we really help me feel better there. And so that idea of a shared care plan is incredibly important. The other is inflexibility and shared accountability. So shared accountability is incredibly important. And, I think as a behavioral health provider, I think about it as what is on that patient's problem list. And I like to say, it's sort of Verna's ease, which is like every provider, every diagnosis, every time. So if you have diabetes, I could say to you, I see that, you have diabetes and that your A1C is here, or that you just got started on a new medication. How's that going? And then I can have a conversation there and maybe provide some medication support, right? It doesn't mean I'm practicing out of scope, but I'm actually supporting everything that's on that patient's clinical problem list. And I'm also accountable. I can see that you've missed 2 appointments for your mammogram. Let's talk a little bit about what are some reasons that you may not be able, to participate in the mammogram, like what's going on, so that we're all shared accountability. I'm just as accountable for someone getting their PAP or their mammogram or their flu shot as the primary care provider is for making sure that their suicide safety plan is reviewed. And so this idea of shared transdisciplinary care really means that shared accountability and that shared care planning sort of across your service lines, but particularly with your behavioral health. And that is actually going to make the difference. We know that teams that have the shared accountability actually do way better and really do come together and function better. That shared accountability, that shared care planning is going to be really key and is going to be incredibly important. And so when we think about that, oops, sorry about that. We think about that accountability, right? We think about addressing every problem. And also, that cross training. I had an aha moment one time. It was some years ago, but I never forgot it. I was working and overseeing and doing a training for behavioral health providers that worked in federally qualified health centers. And we asked a question about diabetes, and a large majority of providers in the room didn't actually know what diabetes was. They couldn't answer questions. They didn't actually understand what an A1C was. And so that idea of cross training is incredibly helpful. We need to be cross trained. How important is suicide? ACU does a wonderful job of training primary care providers on how to identify and care for someone at risk for suicide in a 15-minute visit, right? And so what does that look like? That cross training is so important. And again, what it means is maybe I come in to see my primary care provider and they say, you know what, it looks like Vern is caring for you for your anxiety. How is that going? Oh, it's actually not going very well at all. In fact, it's really a problem because one of the things that I'm supposed to do is I have this picture and I hold it and I do some breathing. But what I'm finding is that I only have the one picture and sometimes I forget it or I leave it at home and I'm going to work and say, well, you know what? Would it be helpful if we made a copy of that picture right now so that you had a couple and you could put one in your purse, you could put one in your desk at work? And so is that primary care provider trained in anxiety? No, but what they're doing is reinforcing the work that I might be doing with that patient around anxiety. And I would be reinforcing the work because I can have enough of a conversation around diabetes and they can have enough of a conversation around anxiety. And so that accountability, that every problem, every time is really what the spirit of transdisciplinary care is. And that if we realize or if we can get to the point where we can have that happen on the ground, then you really have sort of reached that gold standard of what we really call transdisciplinary care. So I wanted to give you something to think about your entire population around behavioral health. Populations or some ways that we're starting to think about it for your entire behavioral health population. And so like to think of it a little bit about we have patients that just need health and behavior interventions. These are your smoking, your weight loss folks, and one and done. I call them one and dones, but they're people that we could see for behavioral health and primary care that maybe just need one conversation or one interaction. We often forget that that's possible, and oftentimes what may be helpful for a certain population of people, right? Maybe you're struggling with your eating, you've just started on Ozempic, and maybe I do some mindfulness with you and maybe you say, listen, I'd like to maybe come back or let me see how it goes for me and I'll be in touch, right? So these health focused interventions. There are the health and behavior codes for them that can be used by different disciplines. Many states have sort of followed CMS in your ability to build those out, right? The codes are here for them, but to think about them as a very separate and distinct population. And then to think about how do we know we're successful? So there are some tools. There's the medication support tool that is from the CDC or CDC Healthy Days. They can say, here's how we know that we were successful there. The next is measurement-based care. And if we can measure it, we should, right? And there are a lot more diagnoses now on the behavioral health side that actually have outcome measures. So for most of these, we're going to use the collaborative care codes that we're going to talk about, some of the behavioral health codes, but there are a substantial number of tools now or resources, and we are glad to share one that has all of the tools that are validated for outcome measures in behavioral health. And we should absolutely have outcome measures in behavioral health for attention deficit disorder for adults and kids, for depression, for anxiety, for trauma with the PCL, for bipolar with the PMQ and the PHQ, right? So there are outcome measures. We should reporting on them. How many of our patients meet that goal? Are we tracking those outcomes across our behavioral health population? We would not care for a population of patients with diabetes and not be tracking and reporting on their A1Cs by provider, by practice, right? By age group, by, however we choose to slice and dice. So if we are not actively embracing measurement-based care, then that's a really strong part of developing our behavioral health service lines. And then we think about diagnoses where we don't have tools to measure, right? Like maybe some early childhood, maybe we want to run some family groups, we want to run some other groups. Those are the ones where we're going to build the psychotherapy codes. We're going to get our PPS rate for those. We're going to look at reducing symptoms. We're going to sort of have some tools here that we can use to measure outcomes. And then we're going to have some folks with those more complex needs. And oftentimes we may not want to use individual provider behavioral health slots for them. We may actually want to run groups like wellness self-management, which is evidence-based for this population, and be able to do that. So, and then thinking about addiction and suicide is sort of crossing the gamut across all of these categories. You're going to see individuals that are struggling with substance misuse and, with potentially risk for suicide. And so what this does is say, okay, if we're going to break our behavioral health population into these categories, who do we have that can provide the services? How are we going to know we're successful? And so that we're not offering, I'm going to call them therapy slots to everybody, right? Because not everybody needs or wants a therapy slot. And there are different models of care or different ways to care, different codes to use, different practices to use, sort of where people are in these buckets. And so if you haven't really thought about this, and broken your behavioral health services and population down into these buckets, then that might be something to think about doing as an organizational or department activity. Going to talk a little bit about some of the different models and give you some things to think about. Many of you may be familiar with collaborative care. In my experience, collaborative care is actually incredibly misunderstood by a lot of FQHC behavioral health leaders in terms of what population collaborative care can manage. So collaborative care is evidence-based. Collaborative care adds 2 people to the primary care team. What is nice about collaborative care now, 35 states have actually added collaborative care to their fee schedule. CMS recently got rid of a terrible G code that applied to FQHCs, and now they can use their CPT code for their Medicare patients. The codes were actually added to advanced primary care recently. And if I were to run a report in your FQHC of all of the patients who had depression, who were on a medication for depression, but who never touched behavioral health, that's your population of patients for collaborative care. A lot of times your patients with bipolar, really, they need support, they need medication. Collaborative care is a monthly case rate, and that allows you the flexibility, like your patients at risk for suicide. I can talk to someone every day or every other day and really support a care plan, use some DBT skills. And so collaborative care can be incredibly helpful for really thinking about certain populations of measurement-based outcome care and where those patients may not be ones that would be optimal in sort of your regular behavioral health service lines that you might have. A lot of times FQHCs will also transition people who might be seeing their psychiatric providers back to behavioral health and into collaborative care so that they can optimize their psychiatric resources. So that's incredibly helpful. If people want to really strategize or ask questions around collaborative care and sort of how it fits to your broader behavioral health strategy, then we would be absolutely glad to do that. It is really meant to manage your populations of patients that have diagnoses that have measurement-based outcome. It's not, so it's a lot more broader and can really be an important strategy. The other nice piece is that because of the way the codes are a monthly case rate and their primary care codes, what a lot of FQHCs will do is bring in a master's level student for an internship, have them do collaborative care, gather that revenue, and then move them into a position, right? So that it changes their ability. And because collaborative care is a monthly case rate and a lot of it is telephonic, then that changes your workforce. You can hire people maybe that are in the state as opposed to regionally, and it can help you optimize a little bit or provide coverage across sites where you may not have a provider. It can also help you if it takes you 6 months to get someone credentialed in plans. then it's possible to think about optimizing collaborative care sort of in that time frame. And so collaborative care should definitely be on the radar for you in terms of uh, a strategy for your behavioral health services. It also is really helpful because there are some very distinct and clear pathways around outcomes. And so, as you think of transitioning to like really more measurement-based outcome care, there's some really clear ways for that to happen under the umbrella of collaborative care. So, give you something there to be able to think about. And I just want to go back to this for a second um, because as you think about where you want to go for your behavioral health strategy and populations, part of our job is to, I think about it like a hockey game, like where is the puck now? And then where is it going to be in 6 months, although it's a little harder to predict these days, or in a year. And there's a lot happening in Medicare now, particularly, CMS is putting out some new initiatives. If you haven't heard about Access, then that might be something to look at. And while organizations are likely not going to be able to participate, organizations can direct market to your patients for some of these depression and anxiety measures starting in July. So, like, how are we going to think about our depression and anxiety patients? How are we going to engage them in care? What does that sort of look like? Those are going to be really incredibly important conversations to start to have now. So just starting to think about that. And also for many of you, particularly those of you who may have had funding for community health workers or for other individuals for your medication assisted treatment, it's time to start thinking about what are some of the codes that you might be able to optimize. So some of the collaborative care codes, the 99484, the general sort of behavioral health integration code, some of the others to try to support some of those services that may actually be under the radar now or getting cut or that you're not collecting revenue for. But I think part of what the take-home message is to start to really think about your behavioral health service lines a little bit differently, to start to think about how can we bring in those core tenets of transdisciplinary care. And it doesn't matter. People say, well, collaborative care, PCBA, it actually doesn't matter. It's about thinking about your population and what is going to best serve each of those populations. What codes are you going to use? Who is going to deliver that service? How are you going to make sure it's financially viable? Is probably the most important discussion to have. So whenever we have done this presentation in the past, there have been an absolute ton of questions and discussion. So I did leave actually a little extra time for some questions and discussions. And I know that I've had some questions in the chat. So while people are thinking about other questions and want to put them in the chat, so Ray, that code, and I'll put it in here out to everyone, is 99484. So 99484 is a general behavioral health. So it's 99484. Maybe Josh or someone can put that in the chat for me. And that is a general behavioral health integration code. There are many commercial plans who cover it, Medicare and Medicare Advantage. I would say a fairly large selection of states also have it on their Medicaid fee schedule. It is a monthly case rate. It is 20 minutes a month. And it might be a code that could help support some of the services that you're providing. So again, giving you some things to think about what that looks like. And so, yeah, so exactly. There was something in here around sort of visual disorders and ADHD. Yeah, absolutely. Those with ADHD and overlap with sort of the undiagnosed eye and visual perception disorders. There's so much that's going to happen from also having those shared discussions. We did a project one time where women who had missed more than two PAP appointments, when the behavioral health providers brought that up as part of their discussions, many of those individuals had experiences in their past, which made maybe having a PAP or that experience very anxiety producing or a little bit scary. And when behavioral health providers had the discussion, gave people options, what if you just went and talked to your provider? Could someone go with you? What questions might you have? What does that look like? And sort of have the discussion. Then a large majority of those women actually wound up participating in that preventive measure. And so that's just one of the advantages of sort of having those cross discussions. There's a question to me in the chat around what position do you recommend for your behavioral health leadership? So I think it really depends on your organizational structure, like sometimes chief or sometimes vice president or sometimes director, whatever it happens to look like. But I think most important is the job description and then arming that individual to be able to really have the information they need and be accountable. So if you hold someone responsible for the financial viability of their service line, then they're going to be empowered to meet with the CFO, to ask the billing questions, to want to get reports, to be able to do that. And I would say if your behavioral health service line is not revenue producing, then I would strongly suggest reaching out. We'd be more than happy to set up a time to sort of do a little bit of a deep dive with you, because really you should be generating revenue in your behavioral health service line unless you have an incredibly high uninsured rate. And a lot of times when I talk to CEOs, they're like, yeah, I think I'm making money on behavioral health. It's a little bit of a mystery to me. I don't think my, behavioral health providers are as busy as they could be, and I guess they're doing a good job, but I don't really know. And so we don't really want that, right? Like we want to be able to have clarity, and we want to be able to talk about it. Oh, so I guess I didn't answer that question. It really depends on your organizational structure, what that position, sort of might be. But yeah, questions, comments? This is such a quiet group. How many of you were concerned that you might lose some grant-funded SAMHSA grant um, funding? One of the things we did for FQHCs in a state recently was we got a list from their behavioral health leadership of all the services they were providing that weren't reimbursed. And then we went through the state Medicaid codes and we went through all of the available codes and their payer mix and gave them suggestions about how they might help to make those services self-sustaining. And so that also is an option if you would like to reach out. We're more than happy to be helpful. But if any of you have SAMHSA grants or some others and you have some concerns, then please feel free to share. Okay, so I'm gonna advance to you, Rick, and let you finish out with some of the slides at the end.
Absolutely. Thank you, Verna. Just wanted to let everyone know to first please complete our post-survey evaluation, but also we invite you to join the next webinar in our series, which is going to be coming up on February 18th at 3 to 4 p.m. Eastern. You can actually scan the QR code now to sign up, and you can also contact either myself or Verna directly for more assistance, either whether it's to take a deeper dive into anything that we talked about today or to learn more about our upcoming Behavioral Health Leadership Forum as well. In the meantime, I think if we don't have any more questions, I think we can potentially wrap up a little bit early, unless there's anything you'd like to add, Dr. Little.
No, I would really encourage. I did notice I just went back through a lot of behavioral health leaders here. Feel free to set up some time, but also the meeting we have in July, I really strongly encourage you. It is with behavioral health leaders at FQHCs around the country. Roll up the sleeves. And I know there was always a time when I didn't want to ask questions in my own organization. I wanted a safe space to be able to say, like, God, I don't know how to figure this out, right? I don't know what to do with this problem. That is your place to come with all of your peers from around the country. So I strongly encourage you to join us for that. It'll be
Absolutely. And we
lots of
should,
fun. Yeah.
indeed. And we're looking forward to potentially being able to release information about potential financial assistance to allow people to attend as well. So please stay tuned for that. And if you haven't signed up for our mailing list to be informed of when, we encourage you to do so as well. Great. And I think with that, thank you, everyone. I think we'll give you a little bit of time back in your day. And thank you so much for joining us. We're really excited to have kicked off our webinar series today. Have a great day,
Thank you
everyone.
so much.
Thank you.